Okay, so we're starting rounds. Welcome to Ocular Pathology rounds. And without further ado, here we go. Here we go. Here we don't go. There we go. Here we go. So our first case is a horse. This is a 20-year-old spotted saddle horse gelding. We have a history of suspected diagnosis, which I will withhold from you for now, and secondary glaucoma, about 6 months, which has been refractory to medical management. The patient is otherwise healthy. Nice history. We have the gross image up here, and what you can see on the hemisected view is that the inside of the eye is kind of covered in this white membranous looking material. Especially you can see this carpet along the ciliary body surface and the posterior iris maybe, and then sort of strands of sort of whitish material in the vitreous. There's sort of the retina sort of flopping over like this, but that's probably an artifact of sectioning. It's very common to get artifactual retinal detachment in horse globes. We probably have a little bit of a cataract here too, a bit of a cloudy lens. But this sort of whitish carpeting is the key gross feature that I'd like to draw your attention to. So let's change to our histology, which this is not the case I wanted to show you. This is. All right. Here is our horse globe. So from low magnification, you can kind of see that the surface of the ciliary body is a little bit messy looking. The ciliary body should have 2 layers of epithelium. There's a pigmented layer and a non-pigmented layer, but then in addition to that, we have this sort of pink carpet, which corresponds to that whitish stuff that we saw on the gross. Before we zoom in and look closer, let's skate along the iris and ciliary body a little bit further. There we go. And in some areas in the anterior uvea, you can see that there's too many cells. There's this purplish look here. There's another area too. So looking closer at those cells, we have a lymphoplasmacytic anterior uveitis. Sometimes in these cases, these lymphocytes will actually make follicles with germinal centers. Maybe this one could be, it's a little debatable if it's developing a germinal center there. But just a chronic lymphoplasmacytic uveitis, that's one feature. And then looking closer at that carpet on the ciliary body surface that was of interest. This pink stuff turns out to be sort of this finely fibrillar extracellular material. Here's an even closer view of it. Sort of lacy material. And then like a step down question for a case like this, maybe at least for a pathology oriented person, could be what special stain would you put on this? And the answer, because this is an interactive rounds, would be Congo red. So this material would be congophilic. It would exhibit apple green birefringence, and that means that this material is amyloid. In this eye, as in other cases like this, there's sort of more extensive amyloid carpeting than just on the ciliary body surface. It extends all the way back to the pars plana, and sometimes you should be able to catch it. Maybe. Well, I thought this one, there we go. Maybe that's a little bit there, although there's kind of some shmoo there as well. One moment. Let's get rid of that shmoo. Okay, let's not get rid of the shmoo. But back here, there's possibly a little bit more amyloid, although sometimes maybe some collagen too. So the amyloid can carpet other places than just the ciliary body, but the ciliary body surface is a good place to look for it, is basically what I want to illustrate. The other thing that you can see back here for this horse, the beams of collagen of the lamina curbosa are kind of way back here, pushed a little bit posteriorly relative to the layer of the choroid, which would kind of come across right here. And the histologic features of equine glaucoma aren't necessarily well defined, but this is cupping in a horse and a little bit of atrophy. The beams of collagen are maybe a little bit close here. So that's consistent with the glaucoma that they described. The retina also exhibits variable atrophy in this case as well. Go a little closer to see that better. Very thin retina, barely any layers left. So glaucoma in this horse. But the key features that are diagnostic for this case, to review, the amyloid carpet, especially look on the ciliary body surface, the lymphoplasmacytic uveitis, which can actually be more variable in this condition. And then there's another diagnostic feature, which this case does have them, but it has them less frequently than this other horse that I have. So I'm going to pull in this other horse really quick to show you that feature. So different horse, but similar features, right? Lymphoplasmacytic uveitis, amyloid carpet. And in this horse, there's quite abundant in the non-pigmented ciliary body epithelium. Let me get in focus. Eosinophilic inclusions. So you can see these linear, actually right over here, there's tons. These linear, brightly eosinophilic inclusions in the non-pigmented ciliary body epithelial cytoplasm. One higher. Yes, I can. There they are. This one had them quite plentifully. So three features: amyloid carpet, lymphoplasmacytic uveitis, and the intracellular inclusions that look like this in the non-pigmented ciliary body epithelium. Only the amyloid seems to be a reasonably consistent finding. These inclusions and the lymphoplasmacytic uveitis can be quite variable in this condition, which is equine recurrent uveitis. So both these horses that I've shown you had equine recurrent uveitis. That is the diagnosis that they had clinically in both cases as well. Sorry?
What's the inclusion?
We don't know. I don't think that we know.
Yeah, just a comment on those inclusion materials. They are colloquially known as coolie bodies. Don't try to Google that or try to look that up in books because you're not going to find them as such, although everyone basically knows. I've seen them referred in national meeting presentations as coolie bodies, so people know what they are, but it's yeah, we don't know what they are. We think I've done electron microscopy of them. They're very cool looking, like aggregates of crystal-like material. You can see them coming like right through the mitochondria, some of those cells. We think they resemble, well, they morphologically resemble what we see with what's that condition in rats? You know better than me. Like
Eosinophilic crystalline pneumonia.
Eosinophilic crystalline pneumonia. So I think it is a immune deposit of some sort. But I don't, as far as I know, I don't think anyone tested or defined what those things are. Yeah, so my idea is that they are something like YN2 protein kind of like material. We should have, I think we had this conversation before, but we should keep having it and think about it. Yeah, you be the right guy to talk about this. Yeah, so hang in there, guys. Dr. Gasper and I will figure this out soon.
Investigations are continuing. Yeah. Cool. Any other questions on this equine recurrent uveitis case? Okay. Our next case is really interesting. I mean, they're all interesting, but I don't know, this case is also interesting. We have an 11-year-old spayed female domestic short-haired cat. The history just says glaucoma diagnosed last year and treatment has not been consistent. That's it. So glaucoma in a kitty. The gross view shows that we have some degree of keratitis. The cornea is from here to here roughly, and it's pretty cloudy. It should be, even in a post-fixation section, relatively clear, optically clear, and it's pretty cloudy. The surface is pretty roughened and irregular in some areas as well. There's this interesting material inside the eye, though, too. This sort of whitish material carpeting the inner surfaces. You can see it here, too. You can kind of see it along the lens. So that's interesting. There's also retinal detachment, although this one is a little bit tough to see because the retina is also so badly atrophied. But we can see kind of a stalk of it coming up here, attaching at the optic disc, and then kind of fanning out to the periphery of the globe. It's very, very translucent and ghost-like because it's so atrophied. So those are kind of the key things grossly. Switch to histology. That's good. See, I did put dots in the ones that I wanted. We're going to start with this one. So already in the cornea, we can see why it was so cloudy grossly. We've got peripheral vascularization in the cornea here. We can confirm looking closer. The epithelium ends there. And then all the surface past that is ulcerated. So a pretty broad corneal ulceration. The epithelium doesn't come back in until way over here on this end. And then a superficial to mid-corneal stroma, there's a pretty dense cellular infiltrate. Just because we're going to start from the front and go back, even though this isn't the elephant in the room for this case. Here is the peripheral vascularization of stroma more closer in. The inflammatory cells that are infiltrating the stroma are mostly neutrophils. And the interesting feature about this ulcer is you can see in this peripheral epithelium at the ulcer's edge, there's this segment that's non-adherent to the underlying stroma, and the basal layer loses its polarity. So the nuclei kind of aren't lined up. They're all sort of jumbled. If you walk yourself a little bit back where the epithelium is still attached, you can see that polarity returning, sort of a more well-organized basal layer. While this also doesn't show us these really nice eddies and whorls that we'll see in this epithelium too, that's another feature you'll typically see with this condition. This is indicative of an indolent ulcer, so an ulcer with sort of a poorly adherent flap at its edge. So this cat had indolent ulcer and a neutrophilic keratitis. Another feature that can be associated with indolent ulcers or just subepithelial clefts or bullae in the cornea. This is an artifact right here. You can kind of fit this piece of the cornea back into place right here. So that's ripped off artifactually. But what I'm pointing your attention at instead is this area here, where between the epithelium and the anterior stroma, there's this much more disorganized sort of fibrovascular tissue. So that is, oh, I missed it for a bit. So that is anterior stromal remodeling. And that can happen with sort of detachments of the epithelium, like clefts or bullae or indolent ulcers. So just some neat corneal stuff. But the real reason why I brought this case to rounds, and have apparently been avoiding mentioning until now, is this. So here in the iridocorneal angle, sort of facing the trabecular meshwork, bulging into the area of the ciliary body maybe, and extending up along the edge here is this really densely, brightly eosinophilic material. It's partially mineralized. We've got little basophilic areas here. I don't believe, nope, we didn't decalcify this at all too. So sort of variably mineralized for real. And so this is this very dense eosinophilic matrix. And what this is osseous metaplasia or heterotopic bone. Thank you. So heterotopic bone formation is probably best associated with guinea pigs. For whatever reason, they develop bone in their ciliary body, which can obstruct the trabecular meshwork and cause glaucoma. Heterotopic bone formation in general has been associated with chronic inflammation, trauma, like a variety of conditions. It's, you know, basically a metaplastic response. We'll keep looking in this case because there's some more features to show you, but this is really interesting in a cat. As we look along the posterior cornea, even kind of tracking from that area, there's more of this kind of osteoid or early bone lining the posterior cornea. Didn't have the condenser in again for that one. Or at least osteoid, maybe. And there's some kind of organizing collagen, maybe osteoid. This one I think is a lot more sketchy, sort of in the anterior vitreous area. And there's a little bit back here associated with a more posterior area of the ciliary body. Again, there are areas that are less mineralized and less organized, so it's not really bone per se, maybe osteoid, so sort of some dense collagen, but kind of interesting in context that this sort of material is at multiple sites and kind of lining surfaces. Oh, one more site, actually.
What the angle is.
Same deal. There's also kind of a curled up fragment of Descemet's membrane potentially at the edge here, although it's difficult to be sure. So the other sites that I wanted to show, but there's a similar dense collagen, at least, along the anterior lens surface as well. So this interesting material is being laid down at multiple sites, and it's often associated with this sort of somewhat bland spindle cell proliferation. There's also really severe cataract in this case. You can see that in this section. Basically, this is the lens capsular bag, and it's basically just full of liquefied protein. There's basically no extant lens fibers. So this is a pretty severe hypermature cataract. We didn't see any clear evidence histologically of lens capsule rupture in this case, but one of the thoughts that we had is that this could represent migrating lens epithelium that are undergoing sort of osseous metaplasia or like a mesenchymal transition, which they can sometimes do. The other thing is that this cat has a couple of features that are sort of loosely associated with trauma, although just sort of circumstantial evidence is what you would call it. Easier to see on this side. So one of those features is angle recession. So the conjunctival fornix is way up here, the limbus is way up here, and the base of the iris is way back here. So the distance between the end of Descemet's membrane and the base of the iris and where the base iris usually should be, and where it is now, is much increased. So this is a reticorneal angle recession, potentially just something associated with buphthalmia. So, you know, it's not like a clear cut, like this is definitely ocular trauma when you see this, but it has been associated with trauma in some cases. So it's somewhat of a circumstantial piece of evidence. Similar thing with these thick-walled cysts on the back of the iris here. They can form in the ciliary body epithelium as well. Again, not really something that you would use to diagnose trauma, but sort of something that has been seen in cats with ocular trauma. So sort of circumstantial or loosely corroborative evidence. Other than that, we didn't see any clear cut, you know, causes or evidence of ocular trauma. But it's possible in this case that that may have been what led to this bone formation and sort of this dense collagen matrix that's being added around the eye. There were no neoplastic cells, though, which is something that you might be concerned about in a cat like this. Oh, yeah, we can look at that too.
If you're allergic to the posteriors.
Yeah, I am. So this is actually kind of what's left of retina. It's completely detached and very severely atrophied, corresponding to what we saw grossly, how it was just so thin and translucent. It's basically just a glial scar at this point. There's very little to it. So retinal detachment as well, kind of corroborative, but not diagnostic evidence for ocular trauma. And so something that you might be worried about in a case of trauma in a cat would potentially be post-traumatic sarcoma, but we didn't see any neoplastic cells in this case, which is good. You can also see it that we're looking at right here is optic nerve cupping in this cat. So there was a glaucoma as they described in history. So that's this case. A bunch of diagnoses, in particular, the heterotopic bone formation, which is kind of interesting. Any questions or comments on this case? Okay. The last case that I have for you is the 1-year-old neutered male lion head rabbit. Let's change the gross photo. There it is. They describe an acute onset development of quote unquote white spot in the right eye, per the owner. Seen on 425, an ocular exam was suspicious for phacoclastic uveitis. And they described the IOP. This eye was blue-gray. Although, yeah. And that's about it. So white spot in the eye and presumed phacoclastic uveitis is the history. On the gross image, we can see that this iris leaflet is a little bit more normal by comparison. On this side, the iris leaflet is tamped down onto the anterior surface of the lens. And basically it's sort of flopping down with the weight of the lens on it. So you can kind of see the anterior surface laid out a little bit more flat. And then there's this area of focal sort of adherence of the iris to the anterior lens associated with this white spot, just as the owner described. So that's kind of the key gross feature. So we'll go straight to the histology. So here's that area of posterior synechia, and it's really, really inflamed. So we have the end of a lens capsule here, and I'll show you this closer up in a hot second, but it's broadly discontinuous across this very hypercellular area. Sort of along the lens cortex in that area, there's all of this pinkish stuff, and in the iris that's posteriorly adhered to that lens, there's lots of purple stuff. So lots of inflammation here. We'll do a quick walk around the rest of the eye. And you can see that pretty much what you've got is this area of interest. So moving in, the uveal infiltrate is mostly lymphocytes and plasma cells, so lymphoplasmacytic uveitis. And the area where it meets all of this inflammatory debris associated with the lens. There's lots of sort of variably degenerate presumed eosinophilic granulocytes or heterophils. And then there's this row of macrophages along that. So all of these are sort of epithelioid macrophages in multiple rows. And then there's this fibrovascular membrane. So the posterior iris sort of ends here. And so all this tissue in between here is fibrovascular membrane. You can see a little blood vessel there. Which also is infiltrated by lymphocytes and plasma cells, and then the iris stroma with lymphocytes and plasma cells. So basically a giant granuloma or pyogranuloma on the posterior iris and anterior lens, and this large area of posterior synechia. Looking closer, you can see that discontinuous lens capsule. You can see the inflammatory cells sort of percolating into the lens cortex. And go to the other side of the lens capsule rupture. Somewhere, here's the other end. And the other thing of interest is when you look into this area a little closer, I'm going to pick the area that I liked best, hopefully. Maybe one lower to search around. Oh, you saw something?
Oh yeah, for organisms?
Yes, I am. The left. Oh, wait. This is the area that I wanted. Sorry. There we go. And the other area is probably good too. Mm-hmm. So here we go. You have this material here. Yeah, we can go higher. No, we can't go higher. This is as high as we can go. The arrow. So this is what we're looking at here. And why we're looking at it on the H&E first is just to show off how poorly staining these organisms are. You kind of can't really make out much border on these guys. They're just sort of these dense clusters of something that looks out of place. So that's interesting. So fix this image of what the H&E looks like in your mind really quick.
Just for my curiosity, go before you go on.
Yeah.
Go higher, a little bit higher indication.
Okay.
Next to the fragmented piece of lens there, so or at the end of it. Yeah, go higher. Yeah, keep going.
maybe better staining in this area.
Yeah, I was wondering if those are organisms that stain better.
They could be. It's tough because there's lots of karyorectic debris in this area as well.
True.
Typically, these organisms are sort of oval shaped, like capsules, pills.
They are.
Anyway.
It's just that here, because of the lens and the way sections are made, it can have a thicker area that the H&E doesn't penetrate that well, and then right next to it, something staining better.
That's true. So they could stain better is the point. And also, I mean, the ones we were looking at that I showed you, that like giant cluster, was probably pretty dense as well. Just because it's solid organisms. But we do also have this gram stain. So this is a gram stain, same slide, different stain. And I want to find the perfect ones, of course, but they are everywhere. So these are reasonably convincing here, for example. They are sort of oval shaped. They are strongly gram positive. Oh, yeah, oh no.
I don't know if you can.
Let's see. There's a couple good ones too. Maybe fairly convincing.
Mhm.
It's tough again because there's lots of debris around on this slide. But they're here, and there are actually quite a few of them. Let's try this area too. All these sort of oval-shaped organisms. So this is encephalitis cuniculi. So this is a microsporidian parasite. That is all I'm going to say about the classification right now. The sort of classification of this organism has changed over time. So microsporidian parasite, I think, is the main thing to remember right now. They cause cataracts in rabbits. They cause a phacoclastic uveitis. They can cause lens capsule rupture. They can actually cause pretty severe anterior segment inflammation as well, and can even culminate in corneal perforation in rabbit cases on occasion. So they can cause ocular disease, as well as lots of other things like central nervous system disease and urinary problems. So meaning kidney, renal disease more specifically. They're somewhat of an opportunist. Typically, a rabbit will develop signs after being like immunosuppressed or stressed in some way. Sometimes they can have sort of subclinical infections as well. So,
how are they getting in the lens?
Hematogenously?
So they usually migrating to the lens during pregnancy through the fetal vasculature. So
Hematogenously by the fetal
guys, they
vasculature.
have fetal vasculature that goes all the way to the lens, and through pregnancy, organisms migrate there from contaminated or infected. Are they dams or what are rabbits, females?
Oh, fruit.
Rabbit moms.
Can't remember.
From rabbit moms, and they go in there.
Those.
And then
I
they.
don't think it's dams, but I can't remember what it actually is.
Those as well.
Those.
And then they.
And bucks, does and bucks.
Mhm.
Yeah.
Into the fetal vasculature, and then they stay in the lens. So they're born with the organisms there, and they kind of brew in there until there's a severe enough cataract that there's lens capsule rupture. Then you end up with a secondary inflammation that leads to glaucoma.
How old was this?
1 year old lionhead rabbit, young animal. Any other questions or comments? Okay.
Diagnosis.
Good question. Maybe the uveitis could have been pre-existing, maybe a trauma.
Oh, the cataract.
Yeah, he said, why would the young animal have a cataract? That was the question.
I think the organisms there just cause degeneration of the lens fibers.
The organisms themselves can bring on the cataract. Okay.
Right, that's kind of a congenital infection almost.
Yeah.
And then because of the cataract, you end up with a kind of intumescent sort of reaction, and then the lens capsule ruptures. And so the lens capsule protects the lens and everything that's inside from the immune system. The lens is perceived as foreign to their immune system. That's why you have lens-induced uveitis. So when the lens capsule is ruptured and everything's exposed to the ocular tissues, then you have an inflammation on top of it. But before that, it's kind of controlled and sort of restricted to the intracapsular space. It's just when the lens capsule ruptures that things go awry.
Sort of like a congenital septic implantation, if you will,
Right, exactly.
but not bacteria.
Good to spray the implantation. Cool.
All right, let's.
You don't need to exit the recording.
Oh.
No, just click the.
That's right. I could just click down here. Right? All right. Yep.
Okay, so this is my first case. This is a 10-year-old Chihuahua mixed dog. Came with a history of acute cloudiness, diffuse corneal edema that was worse axially. Aqueous flare, treated for uveitis. Clinical symptoms did not result. Developed an ulcer with hypopyon, hyphema, and blindness. And wasn't nucleated. During surgery, they found some interesting thickened sclera and masses that extended through the sclera beyond the eye. And this is what they are talking about here. So you can see the corneal edema, some haziness to the intraocular medium, little thickened iris. But the main thing, and well, not the main thing, one of the interesting things, if you follow the sclera, you can see a very obvious line right there. So that's the sclera. This is normal. But here and there, you have this outpouchings of like white nodular material attached to the sclera or in the episclera and orbital connective tissue. So let's see what's up with that. Oops, that's the one. All right. Upside down. All right, so right away, here's a cornea. A little distorted. You can see how edematous it is. Iridociliary body. There are what they call hypopyon, which usually means neutrophils, fibrin, and kind of a suppurative infiltrate into the anterior chamber. So you can see some of that here. Here's the lens, the back of the eye, optic nerve and retina. And there are definitely things there shouldn't be there. And you can follow again as I try to make that exercise like on the gross image, but it's a little easier here. You can see the sclera coming around. And on the episcleral space, or the episclera is expanded by these structures. They look well delineated, multiple kind of coalescing. They have a basophilic center. There are more of those around here. You can see the extraocular muscles. So it's an intraconal in a way, like in between the conal muscles in the back of the eye. Let's see what's in there more specifically. This shirt is not really good to clean slides. That's better. Okay, so just wrapping things up a little bit, the more non-specific things, which are kind of still pretty interesting. Corneal edema, the axial cornea, it's markedly sort of expanded and distorted by lots of neutrophils. You can see how the epithelium is irregular. The stroma itself looks somewhat liquefied. And here and there, you got these islands of epithelium diving down. So this is what collagenolisis looks like, or corneomalacia. What was the breed again? Chihuahua. Well, lots of breed. Well, I don't think there's a specific breed. I want to rule out any or Malaysia based on breed, but you know, the Shih Tzus and Shih Tzoid breeds are very prone to that, which is kind of a scary thing. It's great that we as humans, we don't have that, because, you know, a Shih Tzu can come up one day and looks kind of weird, and the other day its cornea is melting away from its face, and in 24 hours there's a hole in there, right? And this is what happens. It can happen on the presence of an infection or lots of neutrophils. The neutrophils will release their content, and there's basically a dissolution, a liquefaction of the stroma. And when that happens, the corneal epithelium loses its basically, you know, it becomes unstable and can't sit on top of the stroma, and it starts diving down. You can see how, you know, these epithelial cells are diving down into the liquefied stroma. So that explained the corneal changes, and also the hypopyon here. So a lot of the neutrophils we see in the anterior chamber are likely a response to the very severe collagen process. See how that's going down. And if nothing happens, if these dogs don't get medical attention, it will rupture. It will go all the way down the descemet membrane, and you end up with a Chihuahua with a hole in its eye. This is fun, is interesting. There is, I think did we call this? Yeah, secondary glaucoma, epiphymenopause. It's all fun, but not as fun as this, which turned out to be a incidental finding. So first thing, this is the tendon of the dorsal oblique muscle. So we know it's dorsal in the eye. And multifocally, we have these granulomas, nice looking multifocal to coalescing granulomas. We know they're granulomas because they have a very specific arrangement with, let me get a little closer, macrophages at the periphery, get some epithelioid elongated macrophages surrounding a core of debris, some of them mineralized, and right there in the middle, we have these structures. They're not supposed to be there. These are nematodes, adult nematodes. They're degenerated. You can't see much of the cellularity, but you can definitely see the tegument around and a cavity in the center. If we look around, they are in varying degrees of degeneration and death. So lots of dead nematodes. It's a completely mineralized, it's a fossil at this point. If you keep looking around sometimes, so we have you know, suspicion in terms of what these nematodes are based on where they are and what we know about them, but here's some better fossilized dead nematodes where you can see some internal organs, the musculature, and here and there, one thing that helps, you might have to turn your imaginoscope for this one, but sometimes in the tegument, you see these bumps and ridges. If you put them together, you can imagine like a ridge that goes like spirals around. This nematodes kind of like help them burrow down. So you can see these bumps, and these are characteristics, are characteristic of the females of Onchocerca. So these are Onchocerca. Most of them are Onchocerca lupi, but I think there could be some other ones. These are, as I said, incidental findings, not necessarily the cause of the ocular disease here. And we see them in very special situations. Oh, here they are. There are more of them. Look a little bit better. A lot of the inflammation and necrosis comes when they die. And then they degenerate, and then you get all this reaction around. Let's see the bumps that I was talking about right there. Right, so these infections are hyperlocal. So there has to be sort of a very particular environmental arrangement for it to happen. It's usually very dry spots and around a water basin of some sort. So the vast majority of our cases come from either Southern California, Utah, more specifically Salt Lake City, like
probably because they go to the ophthalmologist in Salt Lake City, but Salt Lake City and some places in Texas, New Mexico. This dog was from Austin, Texas. Yeah. So, oh yeah, and the first time we started seeing these cases, we received them from Greece, from this very specific location near Thessaloniki in Greece, and same climate, very dry around the water basin. So we think these are aberrant migration of Onchocerca. They end up in that location and they form these granulomas. Sometimes we receive biopsies of those because they can be a little bit more further, forward located in the episclera, to the point that the clinicians will see them as masses and they will biopsy. But in a case like that, the dog was diagnosed with uveitis and glaucoma and was enucleated because of the glaucoma. And these were just incidental findings. Very cool incidental findings as incidental findings go. But so Onchocerca episcleritis. We had cases where they did cause a lot of inflammation and proptosis and kind of a secondary keratitis, but it's not often the case. Yep, scleronematodes, Onchocerca species, collagenolytic, and suppurative keratitis. Oops. Well, that was not an incidental finding. This is an 11-month-old mini-neuter mixed breed dog. They describe an orbital tumor. Yes, we can all agree with that. It's as big as the eye itself. Smoothly marginated on CT, filling the orbit with multiple foci of mineralization, which will be important later. So they sent us a very nice schematic of the mass, and they actually they were suspecting that the optic nerve ran right through the mass, based on what they wrote. And you can see something like this happen. So here's the sclera, optic nerve, the retina, got some beautiful asteroid hyalosis, all that peppered stuff in the vitreous, and you can see the optic nerve coming down a little bit, but the main thing is this enormous mass in the orbit surrounding the optic nerve and extending a little bit further up to the episclera and even the subconjunctival space here. So let's see. The problem with something big like that is sometimes we're not able to fit the whole thing in a cassette. So there has been some. So quick question here, are the parasites always so numerous? You sometimes see inflammatory reaction without the worms. Not necessarily that numerous. Sometimes we see just a few of them. And we've seen both nematodes with just a capsule and a very bland histocytic reaction, but also a more severe kind of a pyrogranulomatous to necrotizing reaction when they are degenerated.
You do sometimes see cases where it's like suspicion for Onchocerca too, and it's just inflammation and like
right.
mineral debris. So really kind of like suggested,
Yeah, that's a good point. All right, so here's the subgross of our case. Lots to look, a lot of eye to look here. This is kind of a cool section. We have the cornea. The cornea is not completely sectioned, but the eyelids were submitted intact. So we have a chance to see the third eyelid coming around here. And if you keep going along, this is the eyelid aperture with the eyelid margin and the meibomian glands right there. You can walk your way into the eye. Everything looks fine for now until we get to the back of the eye, where here we got the optic nerve, the retina, and that mass. Of course, we don't have the whole mass here. We have this section and some additional tissues submitted separately. Sometimes we do that just so that we can, we want to do immunos or additional stains. We can use smaller slides and save us some money.
So looking for the brainwards end of the optic nerve just in case.
Right. Yeah, that's a good point. All right, so here's the optic nerve squeeze or getting the life squeezed out of it. But interestingly, you can see how the mass surrounds the optic nerve, but it's not in or infiltrating the optic nerve. There are some neoplastic cells kind of in the choroid, but they're extending into the choroid and sometimes in the optic nerve head, which is not something we see very often. It's the tumor mostly affects the orbit and peri-optic nerve region. The cool thing that the reason I mentioned that their CT description is that they talked about a tumor that was filling the orbit with multiple foci of mineralization, and we can definitely see those areas here histologically. And that's a characteristic of this tumor, both histologically and on imaging, which really helps with the diagnosis. So there are multifocal areas of osseous metaplasia or ossification, and also cartilaginous metaplasia. You can see cartilage here. Cute little islands of cartilage and bone or osteoid, right? In different stages of differentiation. And surrounding them, you see these neoplastic cells. Moving away from those more mineralized areas, the neoplastic cells, they form these pretty distinct kind of whorls and sometimes clusters and streams and bundles. There is a lot of collagen along with it. And also see those fat cells, these adipocytes, that's native orbital fat. And the fact that the neoplastic cells surround the adipocytes and they're still intact suggests kind of a slow-growing tumor. So the tumor didn't grow all of a sudden and compressed and effaced everything. So probably a slow-growing tumor. In some areas, you can see that progression from the neoplastic cells in the periphery progressing into sort of cartilaginous osteoid matrix here. So this is very characteristic of a orbital meningioma. So it's a canine orbital meningioma. As we've seen here on this section and also in the rows, the margins are definitely affected. This would be, well, if we're close to the surgical margin somewhere, this kind of likes, this looks like our section, but regardless, it was obvious that the margins were affected, so this tumor is likely to recur. And that is very common for these tumors because they are usually very large and infiltrative and hard to obtain clean margins. If you look at a central meningioma, either brain or spinal cord or spinal column, this is what they look like, more like this meningothelial sort of appearance where they form these nice whorls of epithelioid cells. These are not epithelial cells. They that's one of the situations where the suffix oid is acceptable because they look like epithelial cells, but they're not. These are meningothelial cells. And to show a little bit of the additional sections we got, I don't know if we have any optic nerve in there.
Very edge.
Right at the very edge. So let's find the edge. Again, mineralized. Wonder if that's it right there. This could be it. Just a large peripheral nerve. Yeah, looks like a peripheral nerve. So you can see the main problems being this mass causing proptosis. And very often these dogs develop corneal disease because of exposure. But of course, that's the least of their problems. There it is, a little bit of optic nerve there. So you can see, even though it's an orbital meningioma, the meninges, they're here, they're relatively normal. It's a dura mater arachnoid. And what happens, we think these tumors develop from these kind of displaced arachnoid cap cells that we see around the eye of dogs. So if you look at normal optic nerve, you see some of these cells. So these are not neoplastic, these are the normal arachnoid cap cells. they're kind of outside and they normally appear there. I think it's just a feature of these dogs, of some dogs. And we think the tumor arises from these displaced cells. You can see them infiltrating and dissecting between the fat here. So, orbital meningioma. Canine orbital meningioma, incomplete orbital margins. Oh yeah. What happens sometimes, very often in these dogs, and I've showed you how the tumor was definitely compressing the optic nerve, is these dogs are described as blind or with, low visual acuity or lack of vision. And what usually happens is a compressive optic nerve disease where, it causes degeneration of the axons and complete loss of ganglion cells. It's really hard to say much about this retina. You joke that the hardest thing to see in pathologists in pathology is what's not there. So if you look at a retina like that and you're not paying attention, you'll be like, that looks normal. But you will lose the fact that there are no ganglion cells whatsoever in this retina. It's because of the optic nerve compression and retinal degeneration. Let me see. We have a dog to compare here. I don't remember if that Onchocerca dog had any ganglion cells left, but let's give it a try. Okay, so this is that previous Onchocerca dog. Here they are. So you start seeing right away. They're diminished because this dog had glaucoma, but here's a ganglion cell right there. A large ganglion cell, bunch of ganglion cells here, right? A whole lot of ganglion cells in there. See them all? Now see how easy it is to miss this on this dog. Go back to it. Looks relatively similar to the previous one, but it just can't find a single ganglion cell. It's because I said there's something that looks like a ganglion cell, but it's kind of diving deep. But if you keep going around, they're gone. Right, and that's because of optic nerve compression. Okay, so quickly, we have a few minutes. Let's try one more. All right. Good looking classic one. This is a 4-year-old female spayed Great Dane dog. Pretty straightforward clinical information. Iris mass in the anterior chamber with no glaucoma. And we can all agree in the presence of an iris mass. So here's the less affected iris. You can see some of the pigment going around here. So we know that that mass is infiltrating and expanding this iris leaflet, bulging into the pupillary space, posterior chamber, kind of cradling, surrounding the lens. Lens, it's not really happy about it. You can see some of that mass in the ciliary body, right? Optic nerve and retina in the back. So we're going to basically focus on the mass itself. Getting there. So that's a cute looking classic presentation of this tumor. So cornea, you can see the iris leaflet. There's a little bit of the native pigment left behind, and this mass infiltrating and expanding the iris. See how it cradles the lens, and the mass sort of shapes itself around the lens, likely pushing the lens to the side. And of course, it is occupying the pupillary space. So I don't think this dog was seeing much, maybe just a side look here a little bit. But everything else looks normal. The optic nerve looks fine. The retina looks fine. Even though we have this mass, probably aqueous was able to go through the pupillary space and being drained. And they did not describe glaucoma yet. Okay, so here we go. Let's move to the front of the eye. Let's train this up a little better. All right. So, and just a little bit of anatomy to figure out where we are. Ciliary body. Here's the iris, iridocorneal angle. And we have this mass forming these neat little cords, nests, and these cavitated spaces. So all the things that all the words I've used so far are good descriptors of epithelial tumors. Some of these cavitated spaces, they have variably basophilic secretory material in there. Some of them have blood. So this is a classic appearance of an iridociliary adenoma. So it's a tumor of the iris or ciliary body epithelium. It's a relatively common tumor in both dogs and cats. There are some areas of necrosis. They can be pigmented or regionally pigmented because the iris and ciliary body epithelium, they both have a pigmented layer. But they're obviously epithelial, so that kind of rolls out a melanocytic tumor. These are benign. They rarely metastasize when the margins are clean, like in this case. So enucleation is often curative. See how they can get pigmented in areas like that. And there are not many places where you get pigmented epithelial cells or, in the eye. So if you have neoplastic pigmented epithelial cells, obviously epithelial cells, that is a good point towards the diagnosis of these tumors. Everything else looks fine. Let me just show you how retina looks okay, the optic nerve looks okay. Sometimes we marvel on normal anatomy because we don't get to see that very often. This is a beautiful dog retina. We have, just as comparison, all those ganglion cells and a very thick nerve fiber layer and the tapetum right there. So here we go, iridociliary adenoma. Clean margins. Yeah, it's important to know the classics. And that's what we have for you guys today. Thanks for coming over in person and for joining us online. And we'll see you guys next week. Well, in 2 weeks.
Thank you.
Any prices today, we have $2. We have current and requests. Of course.